I'm welcoming Kimberly Childers here today. And so we are on Zoom and on Facebook Live. So if you have any questions as we go through this, please put them either into the chat on Zoom or into the comments on Facebook Live. I've got some great myths to debunk to start with. And I actually already have a couple of questions that people have sent me. So we will.
Fantastic.
Yeah, we definitely have a full agenda. So these health conversations are brought by the Providence St. John's Women's Health and Wellness Institute. And so this is really our education component. And it's trying to bring you the specialists from our community in an effort, to educate everyone and to really do it in kind of a casual environment where you can ask questions and get some answers and get to know some of our fantastic care providers, one of whom is Kimberly Childers. So she's a genetic counselor at St. John's. And I think a really good place to start is if you would just kind of tell us, the field of genetics, I'm assuming it's pretty new. I don't actually know the age on that, but it would be interesting to hear. And then who are the different care providers in that realm, and what is your training and how did you get here?
Yeah, absolutely. So evening, everyone. My name is Kim. Like Tiffany said, I am a genetic counselor, and I'm also the regional manager of our Los Angeles-based Providence Clinical Genetics and Genomics program. So we see patients out of St. John's and then also kind of span up the valley to Holy Cross and Mission Hills and out to Burbank and down to Torrance and San Pedro as well. So we have a pretty big encatchment for our genetics program here. For me personally, so I was kind of part of the second wave of genetic counseling. There are a few genetic counselors that came before me that trained probably in the early 90s. The BRCA or the Brca genes were kind of the first cancer genetics genes to be identified. And those were in the mid 1990s. So a lot of the genetic counselors that had their training prior to that, cancer genetics wasn't a thing yet. It was all kind of in the prenatal space. I did my training into kind of the early 2000s, and I was part of the second class of the Stanford genetic counseling program. So they started a program that we helped to grow as one of the first two classes that entered into that. I graduated in 2011 and then moved out to Chicago for a bit to start a breast cancer genetics program for one of the underserved community hospitals out in Chicagoland. And then 7 years ago now, which seems like just yesterday, I moved back out to California, which is where I am from originally, to start up this clinical genetics and genomics program for the Providence system. So in our team, there is myself and then soon to be 4 other genetic counselors. We have 2 additional ones joining us this summer. So 4 additional genetic counselors on our team, all trained similarly with a master's degree. Essentially, to become a genetic counselor after college, you do your first year with medical students, and then your second year you branch out and take really kind of genetics and psychology focused classes. And then on our team as well is one fantastic medical geneticist who goes the more traditional kind of medical school route, and then after that does a internship in internal medicine and a fellowship in medical genetics. So she is a leader on our team, as well as the soon to be 5 of us. And that makes us whole.
That's great. So, so right now you live in the Cancer Institute at Providence St. John's?
Yep. So we see patients out of the Breast Health Center, actually. So we are down in the basement of the Cancer Center. If any of you have ever gone to get your mammograms there, we are down in breast imaging. So we see patients in the breast center, but the Cancer Center is right next door. So we often float over there and see patients coming into the Cancer Center as well. So genetics right now at St. John's is largely housed in the cancer space, though we do offer genetic services for some other things as well. If you have family histories of cardio genetic diseases, so things with the heart or neurologic things. So we branch out of cancer on occasion, though our heart and soul is in a hereditary cancer assessment.
That's great. So I know there's some questions about some of those specific branches of it.
Yep.
But we'll get to that. As you talked about when genetics really, became a field, which is with the Brca gene in the 90s. So I sometimes see patients, and I'm sure that you have, and they'll say like, oh, no, like I got tested, in 2000 and it was negative. So can you talk a little bit about kind of that myth or truth and how you think about if you or your family member was tested 10 years ago, 20 years ago,
Absolutely.
how true that information is?
Yeah. So there is a bit of truth to that, I would say. So the kind of timeline of genetic testing in the cancer space in the mid 1990s is when we started to learn about BRCA. And so those first patients to get tested, that's what you were tested for, these 2 BRCA genes. We all actually have these genes, so they're looking for problems or mutations in them by essentially doing a spell check. And so in the mid 1990s, you spell checked your BRCA genes. Then in kind of the early 2000s, they realized that they actually missed a whole bunch of BRCA gene mutations by looking at just the individual way that these letters were spelled or put together. And they had to take a little bit bigger picture. So they had to actually look at these large missing and added pieces, which that initial testing missed. Then in 2014 is kind of the magic year in genetics land. In 2014, they realized not only are there things like the BRCA1 and 2 genes in the world of breast cancer, or something called Lynch syndrome, which is common in the world of kind of colon and uterine cancer, but really there are at least 100 different genes that can cause inherited cancer risks. And these inherited cancer risks can happen head to toe. So inherited risk for brain tumors, inherited risk for hematologic cancers like leukemias or lymphomas, breast, uterine, ovarian, colon, pancreas, stomach, kidney, prostate. Really, most cancers have at least one gene that can have some inherited component to it. And so what I always tell people is if you or your family members had genetic testing prior to 2014, yes, your BRCA genes were checked and they were probably checked relatively well, particularly if that testing was done in the early 2000s and not back in the 1990s. But there are probably 98 other genes that we could look at nowadays that type of testing would have entirely missed. And so your family may actually have these risks, and you or your relative were told, oh, BRCA looks okay, you're good to go. But in reality, it really merits retesting to make sure you're catching mutations in all of those other genes that can now contribute to hereditary cancer risk. And even for people tested after 2014, I always think it's still good to try to get a copy of those actual results just to see what was done. Depending on where they went or who they saw or what insurance allowed them to do in 2014, what was actually tested for, even though the technology to look at more things did exist then. So it's always a good idea before you assume that everything is fine and dandy, just to take a peek back at those results, especially if they were done more than a couple of years ago, and consider retesting for additional genes.
So, you brought up, this is fascinating, and it's like amazing how far it's come, right? Like that. Yeah. It was just in the 1990s, and then it's grown and grown, and the number of
right within all of our lifetimes
genes that we can, it's your word, 100 genes now that you can test for, which is incredible. So you mentioned insurance, and I know that a lot of people have questions about that. And I think in the beginning, a lot of things weren't covered by insurance. Are there still things that aren't covered by insurance? And how expensive is it if insurance doesn't cover it?
Yeah, that's a great question. So what oftentimes people think of is these $3,000, $4,000, $5,000 price tags on genetic testing. And indeed, that was absolutely the case until the early to mid 2000s now. In about 2013, one of the genetic testing labs actually lost a patent. So believe it or not, they had patented being able to test the specific BRCA1 and 2 genes. And when they lost that patent, the cost of testing went way, way down. So even if someone has absolutely no insurance and they don't have any financial hardships, the most genetic testing typically costs nowadays is $250, which has made it much more widely accessible to the general population. With insurance, it also was built into the Affordable Care Act to count as preventative medicine. And so many insurances cover genetic testing in full nowadays. That includes things like Medi-Cal. Most HMO plans will cover genetic testing through their preferred labs. Medicare, if people have a family history of cancer or personal history of cancer that meets criteria. So really, insurance coverage nowadays is fantastic and has become a lot less of a barrier for people than even back 5 or 6 years ago.
That's great. Does it for insurance, does it matter who orders the test? Does it have to be your primary doctor? Can it be a specialist? Does it have to be a genetic counselor?
Yeah, so it depends on the insurance type. So there are some insurances nowadays that do actually require you meet with a board certified genetics provider, either a genetic counselor or a medical geneticist, before they will cover genetic testing. And the reason for that is, number one, to make sure that you're getting the appropriate test. So you don't want someone just ordering BRCA 1 and 2 testing when you could be ordering 100 different things at the same cost to the insurance company. And then part of that as well is just to make sure that patients are well informed to what these different results could tell them, and what a positive or a negative result might mean. Nothing in genetics is black and white. And so some insurances do require meeting with a genetic counselor or a medical geneticist prior to testing.
And so that means coming in or virtually, I guess now you can kind of talk about what the options are. And does that mean meeting with you or meeting with Dr. Ora Gordon? Are those, from the insurance standpoint, is that the same?
Same. So typically in our clinics, the first step is that you'll meet with one of the genetic counselors. So myself or one of the other 4 individuals on our team. We do offer telemedicine appointments where you can, see one of us from the comfort of your home. And then we actually arrange for someone to come to your house to get your blood drawn or a saliva sample collected, or you can go into clinic at any of our 4 different locations and see one of the genetic counselors there. Then once results come back, we typically do most of that electronically, unless we find something that actually merits coming in back in to see us. And that's where Dr. Gordon will often get involved. So Dr. Gordon helps to really manage those patients at elevated risk. So, if you need a breast MRI order, or if you suddenly need an image of your pancreas, she's the one that really helps us to manage those elevated risk individuals.
That's great. There's a couple of questions coming in. I think I'm going to finish with this one because this is about the insurance part. And I remember this, especially in the beginning, that people were really nervous about running things through their insurance because of discrimination, or they're going to know that I have a risk and then no one's going to insure me. Is that protected now? Are those real concerns?
So it is, and they were real concerns, early on in particular. I think we had, a lot of people in the late 90s, early 2000s testing as Jane Does. But in 2008, there was a federal law passed. And so I always let people know, during the Bush administration, it has absolutely nothing to do with the Affordable Care Act. If that went away at some point, this would stay. So there's a federal law called GINA, and it stands for the Genetic Information Non-Discrimination Act. And so that federal law, which is held up in court a number of times, really protects individuals against any type of discrimination by both their health insurance companies and then anything offered through their employer or from employment discrimination based on genetic test results. What is not covered in that law is if you were to apply for any type of private long-term care or life or disability insurance. Those are the 3 things that they did not build into that at the time. But from a health insurance perspective in particular, it's always actually better to run it through your health insurance. They absolutely cannot discriminate against you. And then if you test positive, it is your health insurance that picks up the cost for all of those increased screenings, preventative surgeries, medications, et cetera. So we really, really, really strongly recommend nowadays that patients utilize their insurance for testing because of that protection.
And so the 3 that you said that were not covered by that, have there been any issues around that, the long-term care? And
yeah, so there have been none that we've ever been made aware of. There was one instance about 8 years ago that we had a patient who had applied for life insurance that they wanted to charge him a little bit more for that based on a genetic result. But we actually wrote a letter to his life insurance policy explaining that, and they ended up taking that request back. So we've not had any issues with it to date.
That's great. Sounds like you have a good team that comes together.
We are advocates.
I like
Absolutely.
That. I love that. So, one of the questions I think that people have, and I just got, one question in the box about when, if somebody wanted to see you, how do you know if it's if I need to see you? How do I know if it's appropriate? Maybe somebody had a cancer somewhere, I remember hearing about it, or maybe there's nothing. What if I just want to know?
So what I would say is that, again, with the kind of drop in the cost of testing, genetic testing is available to every single person if you want it. So any person who comes into our clinic and says, I would like to be tested for hereditary cancer, if you don't meet the national guidelines for that, which I'll review in just a moment, you can always opt to pay out of pocket that $250 charge and get that information. So the option is always there, and we don't turn anyone away. You know, if someone is interested, even if they have no family history of cancer, or if they're adopted, or if they have a great grandma with cancer, we will see everyone walk through that risk and walk through testing options. From a who is really at the highest likelihood of having an inherited cancer risk, there are a couple of cancers that if you have even one person in your family with any of those, that meets guidelines, because those cancers are relatively rare and have a pretty high risk of being inherited. That includes things like a single case of ovarian cancer in your family. So if you have an aunt or a grandma with ovarian cancer, even kind of that far out, a single case of pancreatic cancer in your family, a single case of metastatic or kind of high risk or highly aggressive prostate cancer in your family. Prostate cancer risk in men, believe it or not, often translates to a breast and ovarian cancer risk in women. So, you know, if your grandfather died of prostate cancer, that would be an impetus for genetic testing. A male with breast cancer, that's a little bit more obvious one that might be a red flag. And then people diagnosed with cancer at young ages. So we consider under 50 typically to be a young age for things like breast cancer, colon cancer, uterine cancer, stomach cancer, kidney cancer. And then the last thing I'll mention is if you have, you know, multiple relatives with the same type or potentially related cancers, that is another red flag. So if you have, you know, a mom and a grandma with breast cancer, or a mom with breast cancer and a uncle on the same side with prostate cancer, a lot of those can be related through various genes. So if you have 2 or more cases of any type of cancer in your family, it's probably worth a chat.
So if somebody did have these, then they would call, well, I mean, we'll put all these numbers obviously into the Women's Health and Wellness Institute Facebook page, but they would call the Cancer Institute and ask for a genetics appointment. Is that the way that works?
So they would actually call our regional genetics line. So we have a regional genetics line set up, both a phone number and a regional genetics email address. So you can contact us through either of those mechanisms. Oftentimes we need really a note from a doctor to say, you know, yes, I think this is a good idea. That is evolving in our world. So we can always help obtain that from a primary care doctor, for example, if you have one of those, or an OB/GYN. If you need an HMO, if you have an HMO and you need an authorization for that appointment, our office can help obtain that as well. So I would say really, you know, go ahead and give us a call and we can help work through a lot of those steps to be able to get your appointment set up.
That's great. And I'll make sure to put that information in either when we're done here or tomorrow morning. Yep. Depends on how the rest of the evening goes. So
perfect.
So there's, well, I have a bunch of questions. I don't even know where to start. There's so much like good stuff to know. So how about this? What if I want to pay $250, get the testing, everything's negative? What are the odds that I'm totally clear of cancer for the rest of my life?
It's a good question. That is that would be the golden grail. So, yes. You know, we have patients say, well, am I off the hook now? And the interesting and unfortunate thing is that when we think about cancer as a whole, it's really only about 30% of cancers that we see in the US that have one of these inherited components to them. So 70% of cancer, and that's all cancer, breast, colon, ovarian, lung, 70% of all the cancers that we see are actually completely sporadic. They have nothing to do with what we've inherited. It is environmental, age, lifestyle, hormonal risk factors, bad luck, goodness knows what, all probably just coming together at once. So if you have no family history of cancer and you end up testing negative for all of these high risk genes, then you would still have the same kind of general population risk for all of those other environment, age, et cetera, related cancers. If you take breast cancer, for an example, that average risk is actually still about a 10% chance that you would develop breast cancer in your lifetime, just based on those other things. Contrast that with someone, though, that has one of these high risk genes and can be looking at up to a 60 to 80% risk of breast cancer in their lifetime. So yes, a negative test often decreases that risk significantly, but it can't take you totally off the hook. If you have a family history of cancer, there's also this third category, which we call familial cancer. And that's where you can have maybe 60, 70, 80 teeny tiny inherited risk factors that combine with environment and age and things like that. And genetic testing for these familial risk factors is really just starting to evolve. It's something that is now on the market for breast and prostate cancer, but that's it. And it's only in select ethnic populations as well. And so oftentimes, if you have this very strong family history of something like breast cancer, for example, even with a negative or normal genetic test, you may still have a 20 or 30% risk of breast cancer just based on that family history. And so a normal genetic test absolutely cannot take you off the hook in those cases where you may still be eligible for increased breast cancer screening or risk reducing medications just based on your family history alone.
So that's 70% of cancers kind of across the board have no genetic component. So what about the reverse, like the patient who has, you know, a brother and two aunts and, you know, a grandmother, you know, all with a similar cancer, and there's a lot of history there, and all of their testing is negative. How do you counsel them, and then from a professional standpoint, like how do you look at that? How fast are we growing, and are the odds that in 10 years we're going to know a genetic component to that?
Yeah, so it's a good question. And I would say there is a case where really a patient is more largely off the hook, even if they have that really strong family history. So if, for example, my mom has breast cancer and she is tested and she has a BRCA mutation, and then I'm tested and I don't have that thing, then we know, okay, this is the gene that really caused my mom's breast cancer to happen. I don't have that. So now my risk is quite low. It's probably 10% or even lower. So if we actually can find someone in the family to get genetic testing who has had a cancer, that can often help us to clarify a negative result for a patient. In the case where even those people that have had cancer also keep testing negative, we usually say to check in and again in about 2 to 3 years, because genetic testing can change that quickly. So every year nowadays, it seems like we're getting maybe 5, 6, 7 genes added to our panels. And like I said, we're now really better understanding this familial risk space, which makes up about 20% of those cancers. Hereditary is really just the 10%. So I think that we always tell folks to check in 2 to 3 years and kind of see what might happen at that point. And then we manage patients based on family history. So is a lot of literature and fancy math calculators that can be used to say, okay, here's what your family history looks like. Here's what your hormonal history looks like. What is your risk for X, Y, and Z type of cancers? So there are different things that we can kind of do in families where we feel like there's got to be something and we just don't know what it is yet because science hasn't caught up.
So it sounds like we're accumulating a lot of information. Is that because our science is getting better, or because we're testing more people's genetics or genomes, and so we're accumulating databases more, or both?
Absolutely both. So I think that the reason that big change happened in 2014 is the former. The technology was getting better. We were able to quickly sequence or read people's genomes. And that really led to this big explosion from knowing how to test for 10 very specific things and having to go kind of one by one through your list of differential out to 100 different things. So I think that is when the technology piece of it really was beneficial. Nowadays, a lot of the fine tuning aspect of it and kind of these smaller new genes trickling in, so to speak, is largely due to the fact that we're just finding more and more families with these very rare things. So for example, here at Providence, we have a high risk and early detection pancreatic screening program. And so we accumulate many, many families with various histories of pancreatic cancer and are able to identify new genetic risk factors just because we're able to kind of amass data of people with rare cancers in their family. So I think that nowadays, a lot of the research is really looking at these rare families with rare cancers that we haven't found anything yet. And that's why we're able to find a few more of these genes as we go.
That's interesting. So does that mean that when I did my 23andMe, I should have checked that box that says you can use my information? Can we talk about
it's a good question. We can absolutely talk about 23andMe because we do have patients that come in and they say, well, I had BRCA testing through 23andMe and it was fine, so I'm fine, right? So 23andMe it's looking at more of those familial risk factors than it is the inherited risk factors. So 23andMe is often looking at these teeny tiny risk factors for diseases across the board. So if they tell you, you have an elevated risk of breast cancer, you have an elevated risk of heart disease, we're often talking about in reality, a 0.5% increased risk or a 1% increased risk. So 23andMe is really looking at these tinier genetic risk factors, not the big things that we look for in clinic. The exception to that rule is that 23andMe does test for 3 common Ashkenazi Jewish mutations in BRCA1 and 2. So if you are of Ashkenazi Jewish ancestry, it is actually relatively good BRCA1 and 2 testing. And that's because 95% of people with Ashkenazi Jewish ancestry, if you are going to have a mutation in BRCA1 and 2, 95% of them in that ethnic group are one of these 3. That said, even in that population, we recommend clinical confirmatory testing because there have been false positives with 23andMe, false negatives with 23andMe. So I don't know that sharing your data with 23andMe is going to be the next cancer gene jackpot there, but they're certainly trying to work through some of that familial disease risk, which is a beneficial thing as well.
And so I have a specific question about another kind of testing besides 23andMe, and I haven't heard of this, but I'm sure you have. So it's someone who's high risk for breast cancer and did the color hereditary cancer genetic testing. Is that sufficient?
Yeah, so color, the genetic testing through color is indeed these high risk hereditary cancer genes. So from that standpoint, it is looking at the right bucket, so to speak. Where color falls short in some cases is that they do not fully capture the mutations in some of those genes. So for example, if you have a family history of colon cancer or uterine cancer or ovarian cancer, there is a genetic condition called Lynch syndrome that color includes the genes for, but the technology that they use actually skips over pieces of those genes. And so if you have mutations in part of those genes, color would miss those mutations. If you have no family history of cancer and you are doing it just more for an informational standpoint, I think that in all likelihood, it's not going to miss much that would be significant. But in particular, if you're being driven to that testing because of a family history of cancer, and particularly those types of cancers, uterine, ovarian, colon, stomach, then we do typically recommend clinical testing to supplement that as well.
Okay.
But what I will say about color is you don't run into kind of the false positive, false negative issue that you do with 23andMe, because it is using the same technology as our clinical grade testing. It's just not covering the genes quite as well in some cases.
Yeah, so that's so there's a bunch of different tests out there. 23andMe is one of them, color is one of them. And how does anybody know what they're getting, or you just hang on to your results and bring them into you to look at? Is that, I mean, how are people getting all of these?
That is usually what we say. How often is that?
Well, where are people getting their testing? I mean, 23andMe, obviously you can order, online, but the rest of them.
And color is the same idea, actually. So it is meant to really bring genetics to the people. There's another company called Invitae that has a similar product where you can actually go online and kind of order yourself a test kit. Invitae is more comprehensive than color. So if you are kind of looking to go that route, I'd recommend Invitae over color in those cases. But essentially they have genetic counselors on staff and MDs on staff who can sign off on that testing for you as the ordering clinician. So 23andMe is really targeted as a direct to consumer test. Things like color or Invitae, they are still having a clinician order that testing on your behalf. It is just a clinician that they partner with so that they're able to offer that directly to the patient population.
Okay, so that's all super great information, Kim. I'm learning so much. It's awesome. So so there's also a bunch of kind of online questionnaires that people do, and like I know they exist for the Brca gene, and so some people will do those to see if they need to come in. Is there one place where you can get a good one, or a one that's been validated? It's like, say you have a question, you're like, I don't really know if I have enough of a history to go in. Where would somebody go to kind of find that information?
Yeah, so I guess my shameless plug for tonight is that our clinical genomics and genetics website has a patient interactive questionnaire on it. So you can go through, answer yes or no to a variety of personal and family history questions. And then if you answer yes to any single one of those, that would meet criteria for genetic testing. So we keep that updated.
That's a link to a website. So we
Nope, so it's actually our Providence owned genetics website. And I am happy to share that with you if you want to put that up later as well. But
absolutely,
I and the rest of the genetic counselors on our team keep that updated so that as soon as a national guideline for testing changes, we go back in and update that interactive quiz. So that I think is probably the best place, at least from our perspective, to make sure that it's the most updated, because the guidelines for testing change often multiple times a year. So a lot of the times the things that you're using for these questionnaires may well be out of date.
Okay. Oh, so that's great. So it's one website, and they're kind of updating all of those and making sure that you're getting the best current information. So
exactly.
What are
so the like aggressive prostate cancer, for example, that was something that was recently added to those guidelines. So we want to make sure that people are using the most updated information.
Yeah, absolutely. Because I'm sure there's a whole bunch of non-updated ones out there all over the place, right?
Exactly.
Causing needless worry.
Yeah.
So what are the biggest genetic risk factors for in like the women's health space? Like what are the I mean, I think everybody kind of knows about the breast cancer one that's had a lot of publicity, but what else is out there in the women's health space that we should be thinking about and asking questions of our family about?
Yeah, so specifically in the cancer world, really, like I said, essentially any type of cancer, not just our female cancers, can have an inherited risk, with the exception, I would say, of cervical cancer. So oftentimes people say, I had a mom with cervical cancer, I had a grandma with cervical cancer. That's typically not one that we worry much about from a hereditary cancer testing standpoint. That is absolutely much more likely to be HPV driven. The uterine cancers, ovarian cancers, breast cancers, those are female cancers that if you have a family history of those, you may well have an inherited risk for them. Outside of the cancer space, and my training is largely in cancer genetics, and that's where I've spent my last decade. But from the bits and pieces that I know outside of the cancer space, when you're thinking about things like heart disease, for example, that you're really looking for people that have kind of early sudden death. So like the college basketball player who suddenly drops dead on the basketball court. Those types of cardiovascular diseases are often your triggers for an inherited risk workup. Or people that have problems with their heart muscle or function, like hypertrophic cardiomyopathy, dilated cardiomyopathies. In the neurologic space, a really common one that people ask about is things like Alzheimer's disease, where there is indeed a hereditary or familial component as well. But in those cases, you're looking for people that are diagnosed really early with those various conditions. So if you have, people in your family with Alzheimer's in the 30s or 40s, that would be the biggest trigger for a strong inherited risk factor there. And
okay,
there are other kind of disease areas. I'm happy to run through those too.
Well, I mean, those like the Alzheimer's, which clearly has a predilection for women. I think that's a really important space. And there's just, I'm checking all the comments. There's one about how easy it is, the $250 to pay if your insurance doesn't cover it, if you don't have the risk factors, but you want to know. And I think that's a really important thing, because I think, as you said earlier, most of us think it's going to be like $2,000 or something like that. But
right.
The fact that the testing is really nice. And then there's a question about you were talking about cognitive health, but what about genetic testing for mental health issues? Is there a genomind is a word that somebody put in there? Can you talk a little bit about that?
Yeah, and I will wholeheartedly admit that a lot of this actually came out after I was trained. So that is a much, much newer space. And I know, so in that area, you're really looking again at more that familial bucket, so to speak. There are not known strong inherited risk factors for a lot of your mental health diseases, depression, bipolar, et cetera, et cetera. So a lot of that is looking at more of these familial components. The other area that has really kind of come to light in that is medication prescriptions, so pharmacogenomics. So oftentimes if people are going to be taking medications for various types of mental health disorders, they recommend pharmacogenomic testing to see, okay, do you have a body that might synthesize this medication better or worse? Are you likely to be a kind of poor responder or good responder to X, Y, or Z drug class? And so that's an area in the mental health space that has also kind of increased in yield over the last few years, is to be able to really target medication use also.
That's great. So we've kind of talked about like the cancer testing and then some of the cognitive. What about in the obstetric space, or what are we doing there, and what kind of advances have been made? Is that something that you're part of, or is that a different area of specialization?
Yep. So that that is a whole different cancer genetics world. But having had children recently, I am very up to date in that. So cancer genetic testing with prenatal genetic counselors is really the specialist that one would see in that case. Takes a couple of different forms. So what we do often test for is something called preconception testing. So in the case that a young woman or man is getting ready to start a family, there are a number of what they call recessive conditions. So things like cystic fibrosis, for example, where one parent and the other parent may kind of silently carry mutations in these genes their whole life, and they do completely fine because they have a second copy that keeps running and working. But if they both get together and have a child that then inherits, the non-working copy from mom and the not working copy from dad, then you end up with these childhood diseases, things like cystic fibrosis. And so what is typically recommended nowadays is actually before you get pregnant, and when you're starting to think about family planning, you can go in and see a prenatal genetic counselor or ask your OBGYN to run carrier testing, which now screens for up to 250 of these different recessive inherited conditions in the prenatal space. Once a woman is actively pregnant, that leads to a different set of genetic testing. So things looking for Down syndrome, for example, which is now often done in the first trimester, just using a blood test as opposed to your kind of older versions, CVS or amniocentesis, which are much more invasive tests that are done. So that type of testing now exists as well. The last thing I'll mention is that for people that actually have these inherited risk factors, whether they are a cancer genetics risk factor or an Alzheimer's risk factor, if people feel like that is a significant enough thing that they want to avoid passing that down, the other thing that is now available in the genetics world is something called pre-implantation genetic diagnosis, where you can actually test embryos prior to implantation to see if they carry these inherited risk factors or not, to be able to kind of screen for those in the next generation. So that has also changed quite a bit over the last few years.
Yeah, that's remarkable. Remarkable technology to be able to do that. I didn't know that was the word for it. Pre-implantation.
PGD is the short and sweet.
That's good. That's what's way easier to say.
Yeah, exactly.
Easier to say. So what about like the middle ground between like the grown women and the babies? What about when someone has, a daughter who's 10 years old, but they know that they have a genetic risk, say for ovarian or breast cancer? What's your advice when a mom says like, well, what do I tell them? When do they get tested? How do I think about all of this?
Yeah.
It's a tough place to be in.
It is. And I think that that's where the counseling part of genetic counseling comes in.
Yeah.
So from a kind of ethical standpoint, we typically do not recommend testing for these things until it would matter for that person's care. So there are things even in the cancer world that can impact children where testing is offered under the age of 18. But for the vast majority of these genes, there is absolutely no risk for childhood cancers. And so we really, really, really recommend that people wait until they're children are at least 18. And in the case like BRCA, for example, we typically wait until women are closer to 25, which is when you would start screening their breasts if they have these mutations to actually do the testing. So I think that a lot of the times parents, just want to know their daughter's going off to college, they're debating whether to start birth control. There are lots of different things that lead parents to want to know what their child's risk is. But we really try to get it so that young women and young men can make informed decisions as adults when they feel like that information is useful to them and when it is actually useful to their healthcare. As far as telling people about it, though, we usually start that introduction when they ask. So that's really the best advice that we give parents, is that children and teens in particular are really naturally curious people. So if they notice that mom is going in for a mammogram and then a few months later she's going in for an MRI, or now she's going in and having surgery to do something, just being open with your children as to what you are doing will kind of naturally beg questions. And when they start asking is when we start telling. There are, books written about this for talking to very young children all the way up through your teenage years. But the time to start the conversation, that's usually what we'd recommend.
That's great. It's definitely a tough thing, and I'm glad that you guys are there to help with that. What if someone has a family risk, right, or a genetic history in the family, say their mom or their sister has a genetic predisposition, but they personally know that they're not going to have surgery, right? Like, so say my mom has the Brca gene, but there's no way I'm having surgery. Is there any reason for me to get tested?
Yeah. So I think that a lot of us, the reason that many people have heard about things like BRCA is the Angelina Jolie effect. And she had breasts removed and she had ovaries removed, and that's where people's minds go. But in reality, there's really a three-prong approach to cancer prevention and early detection. So I often think as kind of the more drastic end of that is certainly risk-reducing surgery, which for many women is absolutely the right choice. On the opposite end of that spectrum, though, is screening. So for breast cancer risk, for example, in women who don't opt to pursue a bilateral mastectomy, if they have that very high risk, there is screening options, things like breast MRIs, which can catch things that mammograms might miss, various types of ultrasound technologies that can be used. So there is screening that really is aimed at trying to catch a cancer earlier than it might otherwise present when it is much more treatable. So there are absolutely screening that can be done. And in many cases, that's what women opt for a very long time. And in many of the genes that don't cause as high of risk as things like BRCA would, that's really what we more strongly recommend over the surgery option. The other thing that people are often surprised to hear is that there are medications that can actually reduce cancer risk as well. So in the birth control world, women who take hormonal birth control for at least 5 years actually cut their risk of ovarian cancer by about half. In the breast cancer world, there are medications that essentially block your breast tissue from getting activated by hormones that can cut a woman's breast cancer risk in half if they take those for 5 years. So beyond surgery, there are medications that can be used. There are screening technologies that can be used to really help empower women and keep them safe as well.
That's great information. I know that everyone's learning so much, and it's great. And we're kind of coming to the end of our time. And I just want to mention to everybody that in 2 weeks, we'll have Dr. Al Tulak on talking about vascular disease, varicose veins, kind of all of those things that plague us as we get into those years. So so that'll be on June 3rd. So back to genetics. What about if your grandmother on your father's side has breast cancer? Does that mean that it didn't get passed down to you because it's on your dad's side and not your mom's?
Yeah, so I cannot tell you how many times I cannot tell you how many times we have women who come in and unfortunately, they now are sitting in front of me with breast cancer and they say, well, my doctor told me it wasn't something I had to worry about because all the cases of breast cancer are on my dad's side. And that unfortunately is a big, big, big myth. For every single one of these cancer genes, you have 2 copies of them. You got one from your mom and one from your dad. And so, you 50% mom and 50% dad, and these cancer genes absolutely do not play nice. They are not on your sex chromosomes. So they are scattered throughout our genome, and we can inherit that risk from both sides of our family equally. In the same mechanism, you can also pass those down then to both sons and daughters. And so the reverse of that is that sometimes people think, okay, I only have sons, and I've already had breast cancer, so why would I need to get tested? And beyond potentially helping identify whether you have risks for other cancers in your lifetime or better ways to treat your cancer, your sons also then may have risk for prostate cancer, for example, that they should be aware of. So important in both directions there.
Right, or those sons can then have it and pass it to their daughters.
Yep.
Or get breast cancer themselves, even though that's less risky. So I think that we've answered just about everybody's questions. Is there anything that we missed, Kim? I mean, I know that there's so much.
We've done a lot in our 1 hour.
We definitely have. That was a great intro. And so I'm going to put into the on the Facebook page underneath this video where it will live. It'll also live on the Providence YouTube channel, which I think this is our 14th one, and we've just had such a breadth of specialists on. It's been really good. But we'll put the information on how to reach you at the regional level, and then also the Providence website that has the genetic screening questionnaire.
Yep, that is what I was just looking up for you. So if you don't have access to it, I can put it in the chat box as well before I ask.
Oh, okay, great. Yeah, if you want to put it into the chat box, that would be great. And then and then we can put that on. But super helpful. Really appreciate your time. And well, I'll see you soon.
Exactly. Yep. And if anyone has other questions too, feel free to send those along to our Providence email address. Those typically get filtered on to me if they're clinical questions. So feel free, if you have any more kind of personal questions that you want to run by us, to send an email over to us.
Excellent. And I'll make sure that I put those in so that everybody can access them.
Perfect.
All right. Thank you so much. Have a good night, everyone.
Take care.
Bye.